Hello, this is Felice again, and this is a three-part lectures on clinical radiological phenotyping in childhood metabolic and neurogenetic disorders. Uh, and what I will try to do is really to show you how you can use pattern recognition for the most common disorders and how to categorize in your mind and for your clinician this large group of diseases. And as always, I will try to keep it practical and give you some references that you can use if you want to go in depth in this topic. Please check out the other lecture I have on YouTube, subscribe to the channel, and let's go. So this is the summary: leukodystrophy, mitochondrial disease, and the neonate that is not just a smaller child. And I want to start with the classification system. As you can see in this slide that I borrowed from my previous mentor, Dr. Chong, you can classify this neurogenetic and neurometabolic disorders depending on the cellular organelle involved, for instance, mitochondrial, lysosomal, peroxisomal, or the genes or the enzymatic defect. And sometimes there is an overlap between them, and it becomes, especially for a radiologist, very, very complicated. What we could do, though, is to have basic understanding of the clinical presentation or the peculiarities in terms of other organ system involved and use our radiological pattern or pattern recognition approach to try to narrow down our differentiation and then connecting the dots between clinical presentation, other organ system involved, other radiological findings that we have for the same child, try to give a limited number of possible differentials to our clinician. So this is what I will focus, but first and foremost, I want to show you how complex is becoming the world of neurogenetic and neurometabolic disorders, starting with two very important papers, one on leukodystrophy by Van der Knapp and Mariana Bujani, and the second by Professor Shamina Raman that works in our institution in London on mitochondrial disorder. Look at the leukodystrophy. They are no longer only myelin disorder, but they actually involve astrocytopathies, leukoaxonopathy, microgliopathy, so microglia, and also leukovasculopathy. In other words, leukodystrophies can primarily be due to any of the component of the cerebral white matter, including the vessels. So not only the myelin. And look at the number of genes associated with mitochondrial disorders. And this is only the first part of the table to be continued in the next page from this pivotal paper. And of course, we cannot know all these genes and all the patterns sometimes described in a single case report. So we need to find a way to structure our radiological approach and to go from this complexity in this beautiful picture by Karina Ter to this pattern recognition approach that is what is being used in artificial intelligence. So random data become actually recognizable pattern. We know the human brain is the best computer we can have. So we just need to do the same, and we need a bit of experience and a bit of guidance. So let's start with 3 papers that you should download and have in your virtual or physical archive. The first one is from 2 of my brilliant colleagues, Dr. Astik Biswas and Sneha Sudhakar, and it's a very extensive summary of all the different neurometabolic disorders, how they present, and so on. So you really want to download this. And 2 very important papers by Susan Blazer, one of the on neonatal inborn error of metabolism, and another on the inborn metabolism disorders and the cerebellar involvement. So very, very important, both of them. Please download them. So let's start with pattern recognition approach. A pattern recognition approach meaning basically focusing on the selective susceptibility or vulnerability of some part of the brain in some specific moment of the child life. Neonate have some different areas that are susceptible in comparison with a young adult or a child, and how these appear and how they can guide our differential diagnosis. Now, let's start with this case. This is 14 years old female with speech difficulties and progressive leg weakness and stiffness. That's very important when you see there is a progressive deterioration of neurological performance, because this is really typical of neurogenetic and neurometabolic disorder, that the child goes worse and worse over time. But look at this specific appearance of the corpus callosum. It's very thin anteriorly, and the white matter of the forceps major and minor is actually very bright. And this was a sign that was called ear of the lynx. We like to see in our brain scan some animal shapes and forms and appearances. But if I can give you a tip, first of all, when you see the ears of lynx, think hereditary spastic paraparesis, especially these two genes, SPG 11 and 15, and this has been published in several papers. But remember, it's better to look at the corpus callosum in sagittal, because in axial we have this sometimes physiological hyperintense cupping of the frontal horns that can be misleading. But when you see a progressive neurological deterioration of the especially like leg weakness or motor function in general, small anterior corpus callosum, think hereditary spastic paraparesis. This is an example of pattern recognition. Another example is the famous face panda sign. So where in Wilson disease, you have the typical appearance in of the midbrain that looks like the face of the giant panda, in association with bilateral and symmetrical basal ganglia abnormalities. But again, don't forget to look at the rest of your clinical information. Look at the eyes. The Kaiser-Fleischer rings are very, very typical of this disease, and easier to pick up, to be honest, than the panda face in the midbrain. And also you will have liver problem, in this case, portal hypertension. This is another animal. And then we have the eye of the tiger, typical of brain iron accumulation, in particular due to PCAN, formerly known as Aller-Borden spots, or the tigroid pattern in lysosomal leukodystrophy, such as Krabbe disease or metachromatic leukodystrophy. But this, if we keep adding and adding and adding these patterns that look like animal, what we have is a confusing zoo that doesn't really help unless you have a super memory. So what I would like to do is, from this example, start with leukodystrophy and try to show you how you can have a method and a discipline in the approach of to this a possible neurogenetic disorder, and apply this in your daily life as a pediatric neuroradiologist. So let's start with the part one, and this will be the first of the 3 videos that I'm going to record on this topic, leukodystrophy. So first of all, coming back to this paper done by Mariana Buggiani and Mario van der Knapp, what we learn is that leukodystrophy doesn't mean myelin disease, or at least not only myelin disease. And we have that this definition is very important. The word leukodystrophy has become a term indicating all inherited white matter disorders. So myelin, axon, glia, astrocyte, and vessels. And the first thing that I found very, very helpful is to identify the radiological concept that is the so-called hypomyelination pattern. Now, if you look at the paper by Mariana Bujani, before we go to this case, if you look at this paper, there are a few disorders genetically determined that are only myelin disorder. And I will show you this example. If you look at the literature about the hypomyelination pattern as a radiological pattern, there are more abnormalities that are not only pure pathologically myelin disorder, but can be, for instance, lysosomal disorders that also have a similar pattern. So what I want to teach you first is how to recognize an hypomyelination pattern and how to use this for your differential diagnosis. Of course, this is a lecture, as you could see from the title, for dummies. The situation is much more complicated, and you really needs to study and keep up with growing literature and growing number of disorders. But let's keep it simple. Let's start with this a case of 3-year-old male with failure to thrive, seizure, development delay, and very important, hypotonia and nystagmus. So hypotonia and nystagmus not expected at this age, and it is very important to know what happened to the myelin normally. A neonate will have the central part of the brain, for instance, posterior limb of the internal capsule, a ventrolateral thalamus, a bit of corticospinal tract superiorly in the perirholandic region, myelinated. And the myelin appears T2 hypointense and T1 hyperintense. Then, when the child grows, on T1, the brain becomes more and more hyperintense, or rather the white matter of the brain. And the myelination on T1 is completed radiologically at 1 year of age. In T2, the myelin becomes more hypointense. The myelination shows hypointensity of the white matter. So the white matter becomes more hypointense over time. And at 2 years, apart from some terminal areas of myelination, you will have that the whole brain will be myelinated. Okay, now look at this. So expected times of myelination, completed myelination, will be on T1, 1 year, T2, 2 years. Now look at this 3-year-old child. This is a T2, and we don't have myelin in the posterior limb of the internal capsule, perirholandic, nowhere else in the brain. Also, the posterior fossa normally is myelinated quite early. Look at the middle cerebellar peduncle. They are not myelinated. So what we do in this case? Well, first of all, the signal is bright, but it's not like lighting up. It's this faint hyperintensity that is diffuse. But when we look at the T1 is also bright. So radiologically, this brain looks normally myelinated in T1, as expected in a 3-year-old man or child in general, and absolutely unmyelinated in T2. So we have a T1, T2 discrepancy, and this is the radiological definition of hypomyelinating pattern. This is, for instance, a normal neonate, and you see normally a neonate is not myelinated, but still the ventrolateral thalamus and the posterior limb of the internal capsule are dark in T2, meaning that some myelination is present. Here, there is no myelination, not even in the posterior limb of the internal capsule. So this is an hypomyelination, and this homogeneous hypomyelination is the typical appearance of Polyzeus-Metz-Packer, which is the prototype of true hypomyelination disorders, and then we have Polyzeus-Metz-Packer-like, so other genes involved. But what you say is that basically you have diffuse hypomyelination with normal basal ganglia and thalami So no other abnormalities. Of course, polygeosmic barrier is easy because it's so diffuse and homogeneous that you cannot be fooled sometimes, like in this 4H case. I will come back to this diagnosis later, but you can see there are some areas of unexpected hyperintensity in otherwise fully myelinated brain. You see the corpus callosum, but this is not normal. So there is an inhomogeneous hypomyelination. But as far as the radiological assessment is concerned, you always have this T1, T2 discrepancy, and the T2 is kind of hyperintense, but kind of blended hyperintensity is not the most striking hyperintensity. So this is an hypomyelination pattern. And if you look at the literature, there is a pivotal paper from 25 years ago now in Brain, where a lot of authors, including Mario van de Knapp and Susa Blaise, they said, okay, we have all this bunch of hypomyelinating pattern that we recognize, and now we want to see what other findings in the brain or outside the brain can help us in determine or narrow down the differential diagnosis. For instance, in this case, here you have that on top of the hypomyelination on T2, you have congenital cataract. So you have an hypomyelination with congenital cataract, HCC. Another case is here, again, look at the T2, 15 months, there is no myelination at all, but he also have growth retardation and hypodontia. So we have the 4H, which is another acronym for hypomyelination, hypodontia, hypogonadotropic hypogonadism. And we have the gene for that. There are other, and let me go through some of them. Look at this case. Look at the T1 first. It's very bright, 15-year-old. This is a completely myelinated brain on T1. But look, this signal in T2 is not dark at all. It's not very, very bright like a typical leukodystrophy that I will show you later on, but this is the typical T2 appearances of an hypomyelination. Remember discrepancy between T1 and T2. But what we have in this case is also very, very dark globus pallidi with this intermediate lamina that maintains a bright signal. So you have very dark two aspects or two region of the globi pallidi very well seen. And again, this is pattern recognition. You have hypomyelination, very dark on T2 globi pallidi. Again, come back to this paper. This is typical of fucosidosis. So you have a gene, and this is a lysosomal storage disorder. So remember, diffuse hypomyelination, polyphthalmos Barker, congenital cataract, hypomyelination with congenital cataract. If you have hypodontia and hypogonadotropic hypogonadism, plus hypomyelination, 4H, dark, globi pallida, you have fucosidosis. So we are adding more and more pattern recognition aspect that can help us in the differential diagnosis. And if you look at fucosidosis, this is the neurology, the journal Neurology that has a section, an imaging section. This is exactly what they describe. And you can this discrepancy between T1 normally bright, T2 abnormally bright, and dark signal in T2 of the globi pallidi, which means mineralization, and is very bright in T1. Another situation where the T1 is bright, T2 is bright, like before, but look at the basal ganglia. In this case, there is nothing in the globi pallidi, but the thalami we can see the head of the caudate. Where is the putamen? There is atrophy of the basal ganglia and also atrophic cerebellum here. Look at the vermis. It's very helpful if you deal with pediatric neuroimaging to have some normal cases to compare with. But I can tell you in 6 years old, you don't expect this atrophy. So you have hypomyelination with atrophy of the basal ganglia and cerebellum. Another acronym, very helpful if you don't have a great memory, like me. And this is a normal case from comparison with normal putamina. This is HABC, hypomyelination with atrophy of basal ganglia and cerebellum. And they started with pattern recognition back in the 90s, I believe. And you see the hypomyelination with atrophy of basal ganglia as a recognized radiological entity. We didn't know the gene till very recently when they found this 2BB4 mutation spectrum of clinical and neuroradiological imaging abnormality. And you have extra pyramidal signs, but also a phenotypic continuum and a lot of variability. But this is the basic way to diagnose this. Sometimes a similar pattern in neonate of Roman origin has another gene called UFM1. There is a beautiful paper on, I believe, neurology. But in general, if you call it hypomyelination with atrophy of basal ganglia and cerebellum, you will be right. And again, remember pattern recognition. We learned also afterwards that there is a spectrum from the typical appearances I just described, from cases of HSBC without basal ganglia affected, at least at the beginning, or some of them where this periventricular leukomalacia is the main finding. So remember, there are variability in the between genotype, which is the same, and phenotypical expression. But remember, this constellation of findings is very typical. Speaking of basal ganglia and posterior fossa changes, look at this case. 4 years old, completely myelinated. Look how dark is that in T2, the white matter. But there is something going on a bit weird. And if you want to know everything about the normal appearances of the posterior fossa, there is a posterior fossa malformation lecture in my channel. But still, as far as this case is concerned, look at the dysmorphism of the pons with this asymmetry of the middle cerebellar peduncle. Look at the corpus callosum, very small dysmorphic. Look at the patterning defect and the dysmorphism of the brainstem, small cerebellum, and then going up in the cerebrum, this basal ganglia appear normal in size but rotated, probably because the white matter is abnormal and there is clear perisylvian bilateral polymicrogyria. This is not a normal cortex. So we have abnormality in the corpus callosum, brainstem, including this asymmetric middle cerebellar peduncle, cerebellum, cortex with rotated basal ganglia. Again, I'm describing a unique constellation of findings. They point toward a specific group of disease. So let's repeat it. Dysmorphic asymmetric middle cerebellar peduncle, abnormal brainstem, unusual orientated and dysmorphic basal ganglia, abnormal corpus callosum, malformation of the cortex, cerebellar hypoplasia and dysplasia. This is a tubulinopathy. And again, there is a large variability. Some of the tubulinopathies, they look like with lissencephaly almost. Some are more subtle. There are microtubulinopathies like MACF1 with specific brainstem and so on. But overall, this constellation of findings remains very, very constant and can help you in the diagnosis. Let's stay in the world of the leukodystrophy. And another constellation of findings for you guys is in the context of irritability, 7 months. Again, look at the white matter. In this case, it's not like just faintly hyperintense in T2. It's definitely hyperintense with some sort of striate pattern, which we called tigroid before. Also involvement of the posterior fossa, but do not stop here. The thalami are quite dark in T2. The optic nerves are quite thick, and you have enhancement of the cauda equina. There are only other 2 situations, apart from these diseases, that gives you enhancement of the cauda equina like that, is Guillain-Barré and some viral infection. But in this clinical context, development, again, regression is very important, the irritability, think lysosomal, and this tigroid pattern will be typical of Krabbe disease, very similar appearances, metachromatic leukodystrophy. This is the metachromatic leukodystrophy, again, thyroid pattern, enhancement of the cardioequina or of the cranial nerves. Rarely we can have thickening of the optic nerves. We published in a case in metachromatic leukodystrophy, more often described in Krabbe, but still they look very, very similar. The only difference that the posterior fossa involvement is more frequently found, especially early on in the disease, in the Krabbe. But anyway, they can test both of them. So remember that this combination of finding thyroid pattern, enhancement of the nerves, thickening of the optic nerves, and dark thalami, look at this case, also dark thalami, are typical of either metachromatic or Krabbe. When you see dark thalami in general, think of lysosomal disorders. These are very similar, but there are a bunch of lysosomal and other disorders that are summarized in this paper we published a few years ago that present with dark thalami. Despite this is a very subtle finding sometimes, keep that in the back of your mind, again, to help in the differential diagnosis. But if you see dark thalami and thyroid pattern, a lysosomal disorder, Krabbe, and metachromatic leukodystrophy is more likely. So speaking about pattern recognition, we have seen some central involvement of the white matter, like in metachromatic leukodystrophy and Krabbe, but sometimes we have anterior involvement or predominantly posterior involvement or diffuse peripheral involvement with sparing of the central white matter. So this gradient can be used for your differential diagnosis, and we have several different disease that I will explore in a bit. Just remember the first step is that, okay, I have a leukodystrophy, it's not an hypomyelination, where is located? And going from there, I want to speak about the very, very important diagnosis of X-linked adrenoleukodystrophy. Radiologists have a role in the follow-up and the diagnosis of the cerebral ALD. Normally, this is a peroxisomal disorder related to the fact that the ABCD1 gene that normally allow the long, very long chain fatty acids to become short doesn't work. So we have accumulation and toxicity. What is interesting though is that how the toxicity expresses itself in the brain as demyelination. And what we see on MRI is a surrogate of histological changes. And what we have here are 3 layers of changes, mainly in the posterior white matter, as I showed you before, that are a zone A, burned out zone, hyperintensity 2, hypointensity 1, and in diffusion, an intermediate zone of enhancement and restriction that is active inflammation, very important to trigger bone marrow transplant, that you identify the enhancement. And then the third area of demyelination, but no inflammation, so no enhancement. It's very important. The grading of this, the cerebral involvement is based on a very old paper by Professor Lowe's. It's called the Lowe score for ALD. But remember the importance of the contrast. And remember also variability of the MRI picture. There are several patterns that Dr. Lowe's describes. Sometimes corticospinal tract involved, sometimes it's more anterior or the posterior fossa. So you need to keep this in mind. Don't forget there are exceptions to the rule of posterior involvement in ALD. Another very important involvement is the anterior involvement. And again, don't forget the bigger picture. This is a child with large head. So when you have large head and anterior leukodystrophy, again, the importance of the enhancement, in these cases, there is the enhancement, there is some initial involvement of the basal ganglia, and this garland kind of appearances around the frontal horns. So microcephaly anterior predominance with these extra findings of basal ganglia, enhancement, garlands, think Alexander disease. This is super important, but also super typical. And again, the pattern recognition is summarized here on the left. And this is typical of the Alexander in infantile form. But this is what you find in all the books. What you need to remember, because you can change the prognosis of the child, is this pattern of Alexander. This is a 7-year-old with intractable vomiting, and you have a brainstem lesion with enhancement that was diagnosed initially as a glioma. Now, if you know the histology of Alexander and the histology expected in low-grade glioma, both can have Rosenthal fibers, and you will have a very small biopsy because this is a very critical area. So if you think it's a tumor, you tell your surgeon to biopsy it, the pathology will see Rosenthal fiber and say, well, can be still compatible with a pilocytic astrocytoma. But actually what you have to do, you need to check GFAP, because this location is typical of juvenile Alexander disease. And this is a paper from Zoltan Patai, where they really wrote down beautifully this radiological reasoning, and they basically say, well, a low-grade glioma was considered, but the symmetry was off. So when you see something symmetric, think neurogenetic, think neurometabolic. This was a GFAP mutated patient with Alexander disease. So remember that Alexander disease, again, an exception to the rule, can present like that. And this is very important because it guides, the radiology guides the management. Again, large head and leukodystrophy, but this time diffuse. And look how the brightness of the T2 is different in the 7-month-year-old in comparison to the hypomyelination pattern that I showed you before. So very, very bright in T2, but also dark in T1. So this is not an hypomyelination. This is a pure leukodystrophy with basal ganglia involvement. We do a spectroscopy, peak of NA, non-acetyl aspartate. So this is the constellation of characteristics of findings that you expect in Canavan disease. It's very important in Canavan disease that you remember globi pallidae and thalami are more involved than putamen and caudate that will be involved more in, for instance, mitochondrial disorder. We will see them in the part 2 of this lecture, but remember, Canavan disease, large head, leukodystrophy, diffuse, peak of NAA, and specific involvement of the globi pallidae and thalami. And this is a myelin vacuolization disorder, and it's very, very important to distinguish from other leukodystrophy with large head. Look at this case, again, large head, but we don't have really involvement of the basal ganglia, and we have this cystic vacuolization of the temporal folds. And we also have and help from our clinician with this discrepantly mild clinical course with the horrible looking brain, anterior temporal cyst, large head, typical of megalencephaly with leukodystrophy and subcortical cyst. MLC, this time is astrocytopathy, but as far as your radiological approach is concerned, ask how big is the head, look at this rarefaction, this cyst in the temporal, and not only, sometimes in other subcortical areas, and the basal ganglia are spared. It's so important, the clinical mildness of this MLC, that in some case you have the typical pattern, like in this case, and look at the rarefaction, is more peripherally, on top of the anterior temporal lobe. But this is the first scan, 15 months that we did. Okay, the child was a bit ataxic and so on. And then we repeated the scan. The child still had this large head, but the scan was completely normal at 12 years of age. So 11 years down the line, the scan resolved. So remember, the MLC has, again, exception to the rule, like the other leukodystrophies I showed you. And one of these is that MLC2B, due to HEPACAM mutation, is an early clinical presentation of MLC that improves over time, both clinically and radiologically. So remember that if you see something like that, then improves, you are not confabulating or hallucinating, but it's actually a form of MLC that goes better over time. Now let's focus on these findings of the anterior temporal cyst. We can have anterior temporal cyst with a bunch of lesions. So what I like to do, well, there's a bunch of pathologies. And what I like to do is to focus on this finding, which is anterior temporal cyst, and add other associated findings like head circumference, presence of calcification, and so on, and try to figure out the differential diagnosis. If you have a small head and periventricular calcification and the child is deaf, think torch infection like cytomegalovirus. If the child is very sick, very microcephalic, typically basal ganglia calcification, think Aicardi-Gouttière, especially in the context of associated leukodystrophy. If you have this very abnormally Z-shaped brainstem, cobblestone lissencephaly, and cyst, not only temporopolar cyst, but also in the cerebellum, think congenital muscular dystrophies like Walker Warburg. And this paper is very nice, and they give you this nice flow chart where you can use to distinguish these diseases from the MLC that I discussed before. So remember, basal ganglia calcification, think Aicardi-Gouttière, and periventricular calcification, more common with torch infection. Let's focus now on the cerebellar cyst. Very rare to have cerebellar cyst, especially microcyst. We have three forms. We have seen already here on the left the congenital muscular dystrophy, Walker Warburg, but you can have a situation where you have this abnormal fourth ventricle, abnormal cerebellum with the microcyst, but completely normal cerebrum. And this is typical of LAMA1 Poretti-Bolthauser disease. Or you have microcyst, this we saw, CMD, microcyst with bilateral polymicrogyria, typical of GPR 56. Very rare, but again, to show you the combination of findings can help. Of course, we can have large cyst with calcification in context of leukodystrophy with calcification and cyst, also involving the cerebellum. But as far as the microcystic appearance of the cerebellum is concerned, this is very rare and point out toward these three group of diseases. I stop here, and we will see you back for the part 2 on mitochondrial disorders and mimic. Thank you very much. See you in a bit.